need to stay gone for at least 14 and
So let's start by in another minute.
Okay.
Yeah. Can we go ahead?
Yes, please.
Yes. So, hi everybody. A very warm welcome to ladies and gentlemen around the globe who are watching us live now today. I'm Dr. Preethi, Senior Consultant, Cataract and Refractive Surgery from Dr. Agarwal Eye Hospital, Hyderabad. And I thank Dr. Ashwin and Dr. Karpagam for inviting me over to moderate today's session of Dr. Agarwal Eye Hospital's Grand Rounds, which is titled Refractive Surprise, What Went Wrong and What Next? And cataract surgery is one of the most commonly performed eye surgeries around the globe. And it is becoming more and more a refractive procedure which aims to give us spectacle independence. So a refractive surprise is a failure to achieve an intended post-operative diffractive target, which is a definite trouble for both patients and the surgeon. So we have with us today a very wonderful speaker and an eminent panel for discussing about ways to handle the same. So I take great pleasure in welcoming our speaker and panelists for the day. I welcome the very renowned dynamic phaco-refractive surgeon, Dr. SUJATHA Mohan ma'am. She is the Associate Medical Director of Rajan Eye Care Hospital from Chennai, Director Rotary Rajan Eye Bank, Chennai. She is also a specialist in external diseases and cornea and has numerous publications, presentations, and awards to her credit. We welcome you, Dr. SUJATHA ma'am. We also have with us in our panel Dr. Lionel Raj, the Medical Director, Academic Director, Dr. Agarwal Eye Hospital, Tirunelveli. He is very well known, a very methodical, result-oriented phaco-refractive and a corneal surgeon. He is also a very innovative thinker with a lot of scientific papers and awards to his credit. We welcome you, Doctor.
Thank you. Thank you, Preethi.
I would now like to introduce and welcome our keynote speaker of the day, Dr. Carl Stonecifer. Dr. Carl is a brilliant surgeon and a very sought-after speaker on cornea, cataract, and refractive surgery. He is certified by the American Board of Ophthalmology. He recently received his second Achievement Award from the American Academy of Ophthalmology and is listed nationally as a top 50 ophthalmologist by cataract and refractive surgery today. He has extensive surgical experience performing more than 78,000 refractive surgical procedures and over 36,000 cataract surgical procedures. He had his medical degree at the University of Oklahoma Health Sciences Center and completed his residency in ophthalmology at Tulane University. He completed a fellowship with Dr. James at Meggie Eye Institute at University of Oklahoma College of Medicine in cornea and refractive surgery. He also has an additional qualification from Stanford University. Dr. Karl is recipient of more than 15 research grants and actively participates in FDA trials. He has extensive list of publication in peer-reviewed journals and has authored more than 100 book chapters and abstracts. He's a very recognized teacher and a mentor to the next generation of ophthalmologists. Prevention and management of refractive prediction errors following cataract surgery is his most recent article in Journal of Cataract and Refractive Surgery, which was published in August 2020. And that's just to mention one of his many, many publications. Thank you so much, Dr. Karl, for saying yes and being with us here today. And before handing over the session to the speakers, note to our viewers of the session, please keep posting your questions on our Dr. Agarwal's Clinical Education YouTube channel, live relay chat box, and Facebook live chat box as well. We have our online representative who makes sure the questions are viewed by all of us, and we will be definitely answering each one of them at the end of the lecture during the panel discussion. So I again extend a very warm welcome to Dr. Karl, Dr. SUJATHA, and Dr. Lionel Raj. On to Dr. Karl, please, for his lecture.
Thank you guys very much for having me. It's very humbling to share this platform with you all. Rakesh, I assume you're seeing my screen and it's all good. So today, the topic is one near and dear to my heart, because if you've done, and I've tallied up my surgeries just for you guys, 118,781 surgeries, that means you've done it wrong before. So experience means that you've done it wrong before is what I've learned through all these years. And so the best surgeon is maybe not the one that gets it right, but what does he do or she do when they get it wrong? And how do they get themselves out of the problematic case? I have to mention the current disclosures. I've got a lot. I do a lot of research. I consult. I do a lot of lecturing. And we, like she said, do a lot of FDA trials. But I hope none of those are going to influence what I'm about to say today. So the Ardor Walls, I love you guys. I love the people that are on the panel. All y'all are near and dear friends, and it's an honor just to be sharing the podium with you. But we all stand on these giants before us that are living legacies. And for me, this is just a small crew of the people that have helped us get to where we are with some of these technologies that we're working with. But my wife always reminds me, and she keeps me more humble than probably anybody, if you keep talking, sooner or later, something you say is going to sound intelligent. So hopefully today you guys will get something that I'm talking about that makes sense. This is from a friend, Carmen Barricare, Dr. Barricare, Professor Barricare. This is him doing in situ keratomelusis in the 1960s. So they've cut the top of a cornea off, they've creolathed the cornea, and then now they're shaping that cornea to put it back on. So all of you are looking at that and saying, oh my gosh, that's the craziest thing I've ever seen anybody do. Well, when they look back and see what you and I did 40, 50 years later, they're probably going to be saying the same thing. This is a paper that we all participated in. It's on this exact topic. I'm going to make it available to everybody. It's on the prevention and management of refractive prediction error following cataract surgery. We just published this paper, as was mentioned, but it covers this topic in detail, but we're going to go into even more detail and kind of what's new and what's out there. It's just a great resource for the resident, for the practicing ophthalmologist, the optometrist trying to talk to their patients about what options are after cataract or refractive surgery. So I always like to start with the answers, okay? So where are we now? What do we expect? What can we get from our current outcomes? So I took my last three topics that I presented at the American Academy of Ophthalmology, the Corneal Visual Summit, and the Ocular Surgery meeting out of New York. So I think this is very important because when COVID came around, we all were kind of sitting there going, okay, what do we do now? We still have this simple goal. And our simple goal is we want everybody to see what they saw without glasses or contact lenses. So we want it to be this seamless transition from where they were wearing some type of shareware like glasses or contacts or whatever their device was. And then basically now they see and do their daily activities of living and whatever fun for them is without having to wear glasses or contacts. But now we have to add, we got to keep them safe too. So before COVID, this was my LASIK workout. And I'm dividing LASIK and cataract surgery too. We did wavefront, Vario, Pentacam. We did wavefront, manifest refraction, cycloplegic refractions, intraocular pressure, slit lamp, fundus exams. Before COVID, post-operatively, saw you on day 1 week, 1 month, 3 months, 12. Did a very detailed examination. But then COVID came and we said, ups, we got to do something different. Okay, we got to change the game. We took a month sabbatical. So as I call it a sabbatical, it sounds better than kind of being laid off for a month. But we just didn't have really a whole lot. And so after COVID, I spent that entire month thinking about what am I going to do? How am I going to rearrange my office? And we have become much more efficient. The average time a person is now spending in our office on a surgery day is between 45 minutes and 1 hour. That's from the time they walk through the front door, they have surgery, and they leave back to their loved one. So how are we doing these things? Well, we've got all our diagnostics in one room, our refractions, everything are done in a dedicated room, and our exams are done in a dedicated room, and we're not dilating, we're not cycloplegic, which a lot of surgeons don't routinely do, but we did. I still do dilate for mixed astigmatic, I still dilate for high myopes. We still, these new devices, these non-mydriatic cameras can see way out to the periphery. NIDAC makes a great one. We're using the DRS Plus. It's very cost efficient. And a lot of times I can see better in the periphery with these devices than I could see before with my indirect. I can show to the patient, hey, look at this dark thing out in the periphery that no one's told you. I think it's a mole, but I want my retina surgeon to look at that to make sure that's not something we need to be more concerned about than you having refractive surgery or refractive cataract surgery. So this is kind of where we go. The patient arrives, they've already been consented, their money has already been collected by telemedicine. That's already done. So when they walk in, we check their temperature, we ask them the typical COVID questions, we head them straight to their own specific room. All right, that's where they're going to stay, that's where they're going to be, and that's where I'm going to see them. They leave that room, and then from that room, they go straight into the operative suite. So here they are checking in. We've got plastic out in front. They've got all their paperwork already done. If they have any questions, they write them down. They'll come back into the operative suite. We go through the Forcities analytic engine that I'm currently using. They come back to this room. Constantly, my front office staff is texting their loved one and saying, hey, your loved one just went back to surgery. Oh, by the way, your loved one had a successful surgery. Oh, by the way, 5 minutes, she's going to be back out. Can you pick her up in the drive-through? And then we terminally clean that room and we start right back over. So post-op, we still do that one-day check on cataract patients. We're doing it the day of. So today I'll do a volume of cataract, and each individual patient is waiting an hour, hour and a half, see if their pressure rises. We see them today, we'll check in with them tonight, and then we don't see them again until 3 months. So what we're doing are those 1 week and those 1 month exams by telemedicine. And anything I have, you guys are willing to have. You know, Jim Rousey taught me one thing is if I give it to you, you can't steal it. So anything I've got, paperwork, anything that sounds good you'd like, please take. This is our simple telemedicine sheet. We ask the patient the same questions. And if they say, hey, I've never seen this good in my entire life, great. If they say, you know, doc, I think I'm having a problem, we have set slots in our schedule for those patients to be taken care of. Now, just imagine if you could eliminate 2 to 3 visits per patient post-operatively for cataract and refractive surgery. That's a phenomenal time-saving mechanism for your clinics. But you ask, what are the results? How did we do? Did we do okay with it? And they're exactly the same. So I looked at 1,026 cases. We looked at enhancement rates before they were at 0.29%, after they're at 0.29%, and on day one. Now look at it. These are day one visions in both eyes. 84% of the patients are seeing 20/15 or better. So that's better than 6/6. So these patients are seeing phenomenally well. They're very happy. Now, don't get me wrong. It's not perfect. Their vision's a little bit blurred, and not everybody's, perfect, but there are, for the most part, very happy patients. And I think we've gotten this level of great outcomes, whether we're enhancing a cataract patient or whether we're operating on a patient for the first time. And we're using all different engines, but we've now gotten to this analytic software called Forcities, which I don't have time to go into, but our enhancement rates are just getting better and better and better, and we publish those results. So for the refractive side, we're more efficient. Our results are the same, if not better. Our efficiency throughput in the clinic is much better. And the bottom line, these are some of the happiest patients because they don't want to come see you if they don't have to. And us as doctors have just kind of said, okay, we've got to do this, we've got to do this. Well, maybe we can step back a little bit now that our surgery's gotten safer. So let's talk about refractive cataract surgery. Where are we now? Well, I couldn't do it better than Warren Hill. Warren Hill rocks, in my opinion. You're going to see this over and over again, some of my mentors. And he just presented a lot of this data the other night. From the paper, they're advanced IOL formulas, and you should be using those no matter whether you have an older biometry. So I'm actually going to show you IOL Master 500 pictures, and I'm going to show you LENSAR older pictures as opposed to IOL 700 pictures, just because I know many of you don't have the latest, greatest technology mainly, but you can still get access, say, for example, to the Hill RBF because it's online for free. You can still do your personalized lens constants because it's online for free. So Dr. Hill talked the other night, and he showed in his first series of the RBF that 90+% of the patients were plus or minus a half diopter at 3 study centers. Now, these are all good surgeons. These are all surgeons that have great hands, but you got to look at those numbers. And I would beg to ask any of you in private, not public, I'm not putting people on the spot, that you're going to find that your numbers aren't in the 90% range of the plus or minus a half spherical equivalent. You're probably going to be somewhere around 75% to 80%. So we went to March 2018, March 2020, and all these brainiac guys with Dr. Hill leading the charge added things: central corneal thickness, white to white, lens thickness, gender, plus additional other items they're putting into the software. And they've gone from this tolerable 78% of plus or minus a half to an acceptable 84%. And now they're up as high as 92% plus or minus a half. So I'm giving you the secret sauce on how to not have things go wrong from a refractive error standpoint on the front side. And this is a simple way to do it. So let's go one step further. That's all cases. That's all comers. How are we doing with the easy ones, the refractive lensectomies? I just gave a talk in New York virtually on the 30-year experience that I've had with refractive lens surgery, where we've taken the lens out for a refractive lens and for a refractive reason. So we're putting in maybe a 5 diopter lens or a plus 40 diopter lens. And you know, in those hyperopic eyes, those really small eyes, effective lens position is a big deal. I believe that the femtosecond laser is a big deal for me in helping define effective lens position. I think it adds to my outcomes. Does everybody have access to it? Absolutely not. Is it standard of care? Absolutely not. But for me, it does add to outcomes. And we published that series in the general population and show that we're on the same day, contralateral eyes, looking at patients that they actually see better with the femtosecond laser. But by 3 months, they're pretty much the same. But in my patient population, they want to see immediately. What's one of the biggest things that happens to cataract patients post-operatively when they have one eye done? They fall. It's a very common thing. And we don't want patients falling and breaking a hip. And one day, we're getting there in the United States now to where we're doing bilateral simultaneous surgery. We do it with refractive surgery. I think in the healthy population, we can do it with cataract surgery. So let's look at some modern, this is from 2020. I presented this in November, and from 5 to 40 diopter lens with up to a 0 to a T9 of astigmatism. 2/3 at that 1 to 2 hour visit are seeing 20/20, 80% 20/25, and 94% 20/30. So if I can have people walking out seeing that well, that's important, and that is a good referral source as well. But the proof is in how they did, okay? Yes, I use intraoperative aberrometry, and that makes a big difference. But my enhancement rates are tiny. So my enhancement rate for premium channel lenses is 1.6%. That's all comers. That's people that have had RK or radial keratotomy. That's people that have had photorefractive keratectomy or LASIK. The enhancement rate for the RLEs is a little bit higher at 3.7%. That's a range of pre-operative plus 12 to minus 26 with up to 6 diopters of astigmatism. And primarily, many of those patients, I didn't have a lens that worked for them. So I may have put in a 5-diopter lens that had a 3.5, 375 diopter correction of astigmatism, but they had 5 diopters of cylinder, or they needed a 3-diopter lens. Well, I still wanted to do a trifocal lens in, say, a 26 or 27-year-old patient. So I spoke to them about, hey, we're probably going to have to enhance this later on. And if we take those people that we knew we were going to enhance them beforehand, 2.1% is where our enhancement rate is for those patients in those far, far ends of the spectrum. And Warren Hill teaches us that it's those hyperopic patients that are more likely to be a refractive surprise. Now you're like, everybody says, can't you just give me the answer? Can't you just give me an algorithm? And if I have the algorithm, then I can go through it. Whether I'm hyperopic, myopic, I'm astigmatic, this is what that paper does. So I'm giving you all the answers, and we're going to talk now about how to get there. I'm not a big fan of piggyback IOLs. I love sulcus fixated IOLs. Our favorite piggyback IOL just got taken off the market. It was made by Star. I'm a big fan of Rayner sulcus fixated lenses. They don't pay me to say that, but I think the sulcus lenses that they create are great. And I know you guys have access to much more than I do in many of those avenues, and we're going to go through that. So let's go through some simple, prophylactic, easy things to do to make us successful before surgery so we don't have to deal with the surprise. Bill Trackler asked me to be in the prospective health assessment of cataract patients' ocular surface, which we called the FACO study. These were everybody that came in. We had phenomenal people like Faraj Majumar. We had Eric Donenfeld, Marguerite McDonald. We had a lot of great names. Damien Goldberg, people in this study, Alice Eritropoulos, a lot of great people that added patients to this. And we were all amazed at how dry a patient came in asymptomatic. 50% with corneal staining, 60% with abnormal tear breakup times, and 1 in 5 had abnormal Schirmer screening. Now, I don't routinely do Schirmer, and I'm going to teach you my little 90-second workup. But the important point about this study is that 1 in 5 patients came into a typical United States office, and they had what? Dry eye disease that needed to be treated. What? To get better biometry. That needed to be treated to get better K readings. That needed to be treated so that post-operatively they could see and do better. This is my 90-second workup. You can get this. It's in the eminent domain. I'm going to include it in my little package that we're going to disseminate. The OSDI is the Ocular Surface Disease Index. Fluorescein staining of the cornea, not fluoresce because it has the anesthetic in it. Tear breakup time and lissamine green. Those are the simple things. Many of us don't do it as much anymore, maybe applanation tonometry, but fluorescein is readily available. You can put it in, you can look at the corneal stain. Tear breakup time, we can all count 1 Mississippi, 2 Mississippi, 3 Mississippi, or use a stopwatch, and lissamine green, and flag those patients that are abnormal. And my office staff, I have now enabled to do that for me. So my office staff does this before they even get in the room with me, and then I can have the educatable talk about, you have an ocular surface disease that you didn't even know about. We're going to treat that. We're still going to do your cataract surgery, but we're going to treat that prior to. And it saves us so much time in the lane. Now, this is an old ad from the 1950s, 21,000 physicians saying smoking is good for you. So what are we missing, okay? Well, it goes without saying you have to have a normal retina and a normal nerve. So my mother, who I operated on, had early age-related macular degeneration and a huge family history of wet macular degeneration. So we didn't put a premium channel IOL in her. We did monofocal with monovision. My father-in-law, who I operated on, had glaucoma. I'm not going to put a premium channel IOL, but I would consider putting in maybe a Vivity or an Enhanced type of lens in one of these patients that is presently becoming available in the U.S. All of these patients walked in for surgery within the last month. I just picked the abnormal ones, took a screenshot, and I made this slide. Macular holes, epiretinal membranes, cystoid macular edema. And if we're not looking for that, we're gonna miss stuff. So part of my process now in these designated rooms are OCT of the nerve and the retina, screening visual fields if it's indicated, topography on everybody, and then that way I don't miss anything. And I can show these patients on my computer screen now what their corneas look like or what the rings look like and why we're concerned. I love the OPD3. If you're gonna buy one device, it's a bit expensive, but if I were to say, and they don't pay me to say this, this would probably be the one device I would buy. And people always ask me that. It doesn't have pachymetry on it in the OPD format, but they've added that. So I think that that's a no-brainer for me because there is such a plethora of information that you can garnish from one screen. You can get angle kappa, angle alpha. You can look at the topography. You can look at the wavefront. You can look at the Myers themselves, and you can check so many points that we're going to bring up in a moment. Everybody in this slide are family members. We've all had either laser vision correction or we've had cataract surgery. So my brother and I, LASIK, my mother and my sister-in-law, cataract surgery, and my sister-in-law came in for LASIK and ended up with cataract surgery and monovision. Now, monovision is one of those things that I love, but we don't know who can tolerate the binocularity loss and this change in stereopsis. We just don't know unless they've been doing it in a contact lens. We have to do a contact lens trial. I think if you're not doing a contact lens trial, I think you're wasting a step and you're going to end up with more unhappy patients post-operatively because at least you can kind of show them, even if they have a cataract that's not greatly dense, what you're trying to do. And we don't know who prefers what eye dominant and what eye non-dominant and which one they want for distance or near. So this is one of the biggest points that I bring to all. I have 500 physicians that refer into me. And I say, please don't send me a patient that you haven't done a contact lens trial in if you're recommending monovision to that patient. And it works. So they may come in as an accountant and they want their dominant eye to be their near eye. Or they may come in as a pilot or a truck driver and they want their dominant eye to be their distance eye. Or they may have a near hobby like seamstress, sewing, or tying fishing flies or something in my neck of the woods, and they may change up based on their hobbies as well, whether they play golf or whether they love to needlepoint. The sweet spot's about -1.5. Alan Faulkner and I did this study that you're seeing now the data from. We presented this back in 2016 at the Hawaiian Eye, but the point that I'm trying to bring home is the free contact lens trial. So again, I'm going to reiterate, why are people unhappy? Dry eye disease, miss. Epiretinal membranes, miss. They can occur in 10% of the natural population. Post-operative refractive error, we're going to miss the mark. For me, it's about 1 to 2% of the cases. And the wrong lens for the wrong patient. Now that can be even a monofocal lens if we're trying monofocal monovision. So we always have people that want to take a picture, but nobody that wants to help, right? So I'm going to make it easy as possible. The first 5 days after the weekend are the hardest, okay? For some of you like me that work 6, then maybe it's the first 6, okay? But I think for the most part, Jack Holliday, like Warren Hill, rocks. And he has taught us centration, biometry, repeatable K readings, data screening, personalizing your lens constant, getting rid of that residual astigmatism or eliminating that astigmatism, whether that's intraocularly with limbal relaxing incisions, laser relaxing incisions, toric IOLs, and of course these 4th generation formulas. And I think if you're not using the 4th generation formulas, you should start. And if you look at me and say, I can't afford to buy that, I'm telling you it's free online. You can get this stuff online at Dr. Warrenhill's software and website. First, biometry. Okay, we've got to look at their angle alphas and their angle kappas. And if they're off by more than 0.6, we just add the numbers. So if they're less than 0.6, a premium channel IOL is okay. If that number, and you don't have to worry about the signs, and the IOL Master 700 has this, the new LensStar have it, they're all on every pretty much prominent new biometry, but that's why I'm showing the old ones, because you add these numbers, forget the signs, and if they're greater than 0.6, you got a problem with premium lenses and centration. And that's going to be typically in your what? Your hyperopic patients, okay? Because they're going to have more of that towards the nose, that positive angle kappa. The best centration is between the pupillary center and the visual axis. And that's, I'm going to show you how to find that sweet spot. Because I think Purkinje is pretty cool as well. And everybody learned this in Optics 101. So you're seeing Purkinje 1 right now. The patient's aphakic, right? So there's normal anterior cornea. I'm putting in this PanOptix lens. So as I'm putting in the PanOptix lens, what's going to happen? Purkinje 4 is going to come into play. See it? It's a different color, and it's the opposite sign. So think about Mickey Mouse. You got a Mickey Mouse looking at you and an upside down Mickey Mouse looking at you. So I have 3 lights, and I'm pointing that out with my Kugelin. I'm sorry, my Connor wand. And so I'm saying, okay, look, that 4 is off from the 1. So Mickey Mouse, big ears, looking right at me, upside down Mickey Mouse, a little bit off. All right, so what I'm trying to do is line those up in the center of my premium channel IOL. So I grab some forceps and say, well, you know, it's not lining up real good. And then she's going to look up, look away. And so now what I got to do, I got to take the viscoelastic out, right? So as I'm taking the viscoelastic out, watch me kind of nudge that lens, and I'll just nudge it and get that lens exactly where I want it. And I want Mickey Mouse upside down to be on Mickey Mouse, right side up. So 1 and 4, and I'm using Mickey Mouse. Sorry, I hope everybody knows who Mickey Mouse is. But I think for the most part, looking at this right now, you see how she's looking away, and in a second, they'll look right back, and they'll line up as she's looking online. So I think that that's a simple way to do it intraoperatively. Now, post-operatively, David Chang showed us that 10% of his patients can change the rotation of a toric intraocular lens by their activity within the first 24 to 48 hours after surgery. So tell these patients, no bungee jumping, no pogo stick, no exercise, go home, don't work, don't lift. If I put a toric lens in you and you come back and it's rotated, I'm going to blame you, because we're pretty good at putting them in the right spot these days. So I think that tell the patient they're part of the process, and then we're going to talk about what happens if those rotate. But ocular surface disease, I know you can take care of. K readings, you can look and make sure they're within the right parameters, good biometry, and developing your own A constant is free now. It is the easiest thing to make you a much better surgeon. So if we look at the standard deviation on our K readings, if we develop some sort of protocol, OSDI, lissamine green, fluorescein stain, 90-second workup in the clinic, this is going to make a difference. And we treat to resolution, and then we repeat the biometry. Yes, it takes time, but if you want to get it right the first time, it takes time. And if you want to get it right the first time and make the patient happy, you have somebody come back, you're going to lose patience for it, because they're going to tell you you didn't do it well the first time. Hot spots on your topography. This is mine. I've got a pretty good dry eye that I've now treated with low-level light therapy and IPL and doing much better. Corneal quality after LASIK. We've got to make sure that that root mean square is lower than 0.5. So these are all things that we need to look at with our devices to help us decide, well, we got a really unhappy LASIK patient on the right and a kind of unhappy patient LASIK on the left, and we got a good reason for it. So what are we going to do to make this patient see better? And it may be leave them with a little residual nearsightedness and maybe come back and say do a topographic guided treatment. There are other ways. We may want to cross-link that patient, but in fact, I put that patient on the right because what they really have is a pellucid marginal degeneration type of picture. And now in those pellucid marginal degenerations, I'm using my T8s and my T9s produced by Alcon, and I'm getting pretty happy results in those patients with severe astigmatism. So we all know these concerns for binocular, axial length difference, K differences, IOL powers that should make us suspicion, monocular, K standard deviations, we know those. Do use the A constants at the beginning, maybe, but you don't have to. Go to Warren Hill's website. If you're too lazy to make your own personalized lens constant and use his, because at least he has 30 or 40,000 patients in the database for some of these lenses. IOL style, lens placement. Dr. Preethi and we just may do different things. We have a different biometry, all sorts of different things. So what Dr. Karl does and what Dr. Preethi does is completely different. And we may even use the same operative suite and still have different A constants. So I think it's important because she may use an Alcon lens and I may use a J&J lens. And those little differences are what make the difference between a successful astigmatic outcome or a successful spherical equivalent outcome. So again, I'm trying to bring it in your head. Epiretinal membranes occur in about 10 to 15% of the normal population. So you want to diagnose that before than after you put in any type of lens. Now, you may not operate on it before. Your retina surgeon may say, go do their cataract surgery, and they're probably going to be happy. But you still want to know that beforehand, as opposed to be having this conversation post-operatively. Oh, I'm sorry, Ms. Johnson, I didn't see that. Dry eye, dry eye, dry eye. Still see it. I see probably about 6 unhappy patients referred to me by other surgeons. And those top 2 are the reasons that have been missed. Dry eye and epiretinal membranes. And then residual refractive error I see all the time is patients are missing on the mark, and I touch that up with laser vision correction. So now, what do we do when it doesn't work? Okay, so pipe up, listen in. Now we're going to talk about all those different options. Now, this is from the article, and these are online, different types of calculators, back calculators that you can use that I think are easy to use. And they also tell you how to do limbal relaxing incisions or laser-made relaxing incisions. So we have a 67-year-old male. Dr. Preethi, I got you live. So I'm going to ask you, all right? They come in to their surgeon and they said, my vision's a little bit blurred. I got a little drop shadow. I'm really active. After surgery, I was running, marathons and doing everything. And the surgeon said, well, let's wait. Let's wait for it to stabilize. I'm not sure that's the right answer, but he's lost a follow-up and now he's here with you. So would you not agree there's a bunch of things that could be? The lens could have rotated if it's a toric lens. He could have leftover astigmatism, new astigmatism. He could have developed a dry eye. So in India, of those options, IOL exchange, IOL rotation, laser astigmatic incisions, limbal relaxing incisions, laser vision correction, smile, what are readily available for you?
So if it's yes, IOL rotation is readily available because there you don't have to replace the lens or you don't have to put something, do something extra. So that is really readily available. And then comes the IOL exchange, I would say, because most of the cataract surgeons who have only cataract setup, they can do both these things. So these are the first 2 readily available things. And then comes the laser refractive correction, because that needs another instrument and another expertise as well, which may not be
exactly.
The
Dr. SUJATHA, anything you want to add?
Yeah, I would go in for IOL rotation as a first option. And we have done IOL rotation even after 3-4 years. So it just needs a little bit of patience and we can still rotate. And since the patient has already had a good vision immediate post-operative period, I think IOL rotation should be the first option. Unless there's a lot of fibrosis and you feel that it might produce more harm, or it has been YAG lasered already and there's a chance of problems in the intraoperative period, then I would go for a laser vision correction.
Yeah, and as I said, Dr. Chang has said this can occur within the first 24 to 48 hours after surgery. So I constantly tell my patients, if something's changed, even by telemedicine, my staff are asking that, how's your vision? Wonderful. Well, there's certain key words that you know. Dr. Lionel, you got anything else you want to add to this?
Well, Carl, I would just look into the quantum of the refractive error and exactly how, how long is it after the surgery. So if it is less than 2 diopter, I would plan for a corneal refractive correction.
Right.
If it is over 2 diopters, I would think about the IOL plane.
Yeah, I'm totally the same way. So this is an IOL rotation after a year, and Dr. SUJATHA is correct, you can, and I basically do different, approaches. I'm trying to leave the original incision alone, but, it takes a little time to get the lens kind of freed up. I'll visco dissect, just like you said, Dr. Lionel. I do a transepithelial pattern with PRK. My good friend Doug Katzif likes to do LASIK on these patients, but I think for the most part, transepithelial, mechanical removal, LASIK are all options. So I pretty much ablate till the fluorescence is gone. Then I'll wait a minute. This is with the VisX laser, and this is a standard S4 VisX laser. And then primarily laser without touching the cornea. I still do mitomycin C on a lot of my patient population. I don't think with the newer lasers you have to do that, but that's kind of built into my nomogram. I will irrigate the mitomycin C after applying for 12 seconds. And for me, I have never, knock on wood, never had a complication with mitomycin C ever with a 12% or 12-second application of 0.02%. And then I put on a bandaged contact lens, and most of these patients are seeing between 20/20 and 20/40. Now back over to the left. You notice over here that I've got no marks on that cornea. Why? Because I'm using intraoperative aberrometry. And a lot of people that you said, Dr. Preethi, that you may not have that. So we have to I use a robo marker. It's a gyro balance thing that I'm a consultant for that company. But I think, I still buy the robo tips if needed when I use them. The biggest issue in terms of marking the cornea works well. Just take the time to do it and take the time to do it well. This paper that I spoke about earlier has a step-by-step approach. Nomograms, Donenfeld, Nickerman. Donenfeld, love him to death. He's one of my best friends. He does this at the slit lamp. I don't think I've been brave enough to do a limbal relaxing incision at the slit lamp. The reason I like the laser astigmatic incisions is because they see so fast. So these are people that have residual astigmatism plus or minus a half to 0.75. And basically I take them back to the intralays. These are intrastromal incisions. So they don't even come to the surface. On the right, you see the typical animation of making astigmatic keratotomies, and I've probably done 20,000 astigmatic keratotomies, but I can do a much more accurate alignment and a much better depth with the laser is the only difference. But you do what you got. I can go and confirm the axis afterwards. If I haven't, gotten a good result, I can add a couple incisions right afterwards. But he's already reading the 20/20 line, and that's 5 minutes after I've done the astigmatic incision. That's how quick and slick it is. And really, I put drops on them, but you really don't necessarily have to have them. All right, Professional Lionel, hop back on because I didn't bug you earlier. You have a 72-year-old female, okay? You did the laser vision correction, okay? You put in the trifocal IOL, and now she's -1. We can make her -2 because you like the -2 is your cutoff point. So what are you going to do? So she's 72. She paid you extra money to get the trifocal. You use the online free ASCRS calculator, and now it's early. Are you going to exchange? Are you going to decide and do laser vision correction? Do you smile? I don't know. Do Indians smile a lot or no?
To me, I don't do smile. So that option is given up. But if you tell it is -2, still I will proceed with the surface ablation with mitomycin C. That will be my regimen after 3 months of surgery.
Yeah, I'm the same way. The reason is because sometimes the effective position of the lens, you taking one out and putting one in can alter your refraction. For me, I have access to laser vision, but Dr. Preethi, I know you said earlier for those that don't, how early would you do an IOL exchange?
This case is actually a trifocal, and then it's a 72-year-old female. So in this, and if it's just -1, I would rather counsel her because most of her activities be near vision based. Like she's a 72-year-old. So I would not even consider doing anything to her unless she's really complaining and she is demanding. So because again, taking her for an IOL exchange, I'll have to do the recalculation, and I would be having my own set of doubts as what if, as you said, if the refraction changes again when I put in a new IOL as well. So if she's really demanding, and if it is -1 or -2, and if her corneal status is fine and ocular surface is fine, I would rather refer her to a LASIK center and get a surface ablation done rather than going in for an IOL exchange. This would be my way of approach.
Now, Dr. Sujatha, you said you like up to 2 years to exchange lenses. So tell me two things. If you're going to exchange the lens, how do you calculate what lens you put in? And if you're going to exchange that lens, when do you decide to do a YAG laser capsulotomy and not? What are your thoughts on that?
This particular case, it's a no-brainer. I would do a laser vision surface ablation and be done with it. And like Preethi said, only if the patient is demanding, because this is very ideal for a patient who reads a lot. A 72-year-old female, at least in India, the main this thing is to read. So I think she's in a very happy place with this -1. But if the patient is demanding that she wants to see better, then I would recommend a laser vision correction. As far as IOL exchange is concerned, I would do an IOL exchange as early as possible, maybe wait up to 3 months, and then I would do, if the patient is still not comfortable with the vision she has, I would do an IOL exchange. And it is based on a formula that the residual power is calculated with 3/4 of the power. There is a formula for that. I'm sorry, I'm not able to remember that formula.
Oh, no. And the only reason I bring it up is because, again, I'm giving you the answer. It's in the paper.
Yeah.
They've got all the directions on how to get to those websites, too.
Well, do you use the Hills Virgins calculator in such a case when you plan for an exchange?
You were asking me?
I'm just telling you, ma'am. Do you use the Hills Virgins calculator?
No.
Oh, yes. I'm sorry. I couldn't hear exactly what you said, but yes.
Okay.
I use more than one. I use Holiday Hill. I'm using a lot of them. I'm looking at different avenues on how to figure out what's best implant. But I'm spoiled. I admit, pick me. I got apparometry intraoperatively, and that's going to help me as well. So you both made comments about these late IOL exchange, and everybody kind of chose LASIK or some kind of PRK. So on the right, you're seeing me talk about making a flap. On the left, you're seeing my late IOL exchange. Now that's with an intact capsule. On the left, you're seeing me lift the lens. I'm going to kind of dissect out the haptics.
So because it's after 1 year, did you do anything specific to make the haptics free? Or
Yeah, so what I'm doing here is my typical technique. And my typical technique, let's see if I can turn that off for a second. My typical technique is to visco elevate the lens, okay? Now, it depends what kind of lens I want to put back, but in this one, this was a simple spherical refractive error in a hyperopic patient that was referred to me late. And so this was hyperopic. And so I have been doing it this way. I don't even remember doing it any different. I put the lens underneath the lens, and then primarily that's a Z9002. So it's pretty easy to make those haptics follow those acrylic haptics. And so principally by me sliding that in underneath, even if I have a non-intact posterior capsule or the posterior capsule's open, I'll flood a bunch of viscoelastic under it. I'll sandwich the viscoelastic between the vitreous and the lens. And I've even done this in vitrectomized patients as well. And so I think that getting that into the spot where you want it. Now, this is where the tricky part comes. And you're right, Dr. Preethi. You gotta think about, okay, how hard do I want to get those haptics out? I'll leave them behind. I'll just cut them off if they seem like they're stuck. There's no reason to rip your zonules out if you're thinking you're going to take them with you. So I gently, and I've edited this obviously, but I gently dissect with like a Connor wand those haptics. And if I can free them up with me putting the lens into position, I make a little smiley face because you don't have to go all the way across the lens. That's a 2.4 incision. I'm dragging this acrylic SN60WF through, and I'm watching that haptic right now, that trailing haptic, and saying, is that thing stuck or is it going to come okay? And I'm kind of rotating it clockwise out of its cocooned position, and then I'm done. Now, if for some reason that was stuck, I wouldn't have had a bit of a problem going in and cutting that haptic and leaving it behind, and have done it on numerous occasions. But I think that, whether you have to do a posterior approach, sometimes I'll do this in conjunction with my retina colleagues. We'll both be in the same room, and I do what I'm good at, and he or she does what he or he are good at.
Can I interrupt at this point? Can I ask you a
Please.
question?
Sure.
Have you tried these piggyback IOLs? Oh, you have come to that.
Please come.
Because
Yes, that's our next one.
Yeah, okay.
So this is my favorite. I love it, Dr. Sujatha, when you help me get to the next point.
Yeah.
So my next point is piggyback IOLs. We got stuck because we don't have a good one anymore. Our good one got taken away that Star used to make. There are others, but we can still get that chafing of the iris, transillumination defects, problems putting things in the sulcus. So a piggyback IOL for me is not my favorite. I'd probably rather do an early lens exchange if I can, as opposed to late piggyback IOL. But what I really do love are these Rayner Sulcoflex lenses. And I know you can get them on one-off basis. I get no money out of this. I'm not a consultant. I don't work with them, but I love the whole company. Rayner, the family have been very nice to me and kind to me through the years. My problem is also Johnny Gayton reported the interface fibrosis that you can get late with a piggyback lens. So these lenses are specifically designed to go into the sulcus. They're made for sulcus fixation. So I think that if we can use something that has that purpose, and I've talked to the Rayners family on many occasions, and they're just saying it's too expensive to bring this lens to the marketplace, the US, in the current FDA climate. But they'll sell these to you on a one-off basis. And in the US, you can get them, I believe, on an orphan need basis for specific patients. But you can get them in a multifocal. You can get them in an astigmatic. You can get them in an aspheric. You can get them in a toric or a multifocal toric. So they come in all these different flavors, and they're so easy to implant. And the other thing is, they're easy to explant. So if you put that in, and because you change the effective lens position, you can take that person out to an autorefractor or a refracting lane, see what their vision is, because you're going through a small incision, folded lens, and if it's wrong, you can take it out real easy and put it back in. So it's easily reversed while you're there, and you can remove it immediately and exchange it pretty simply. Now, the animation is much easier than the real thing always, of course. So quickly, I'm towards the end, the future. RxLAL.
Can I interrupt?
Yes.
I've seen some surgeons using the phakic intraocular lens, the ICL,
Yes.
for correcting residual refractive errors. Do you have any experience in that?
I have not done it because I've seen some intralenticular fibrosis with that lens as well. But I'm not opposed to it because I've seen it work in certain instances, and those lenses are easy to remove. So if that's all you had as access, the low-level star lenses I think would be fine. And they do vault, so I think they're going to vault better than a piggyback lens. So I am not against the star lens. I have not personally done that myself, but I have seen patients with intralenticular fibrosis with that.
Just one.
Aiming at now, another smart guy, the whole point of the next few slides are right lens for the right patient. We have to educate our patients the difference between a bifocal, a depth of focus, and a trifocal, because if they pay anything extra and they miss the middle, say with the bifocal lens, or they're not getting the near, say with the depth of focus lens, that's a problem that we need to solve before surgery. So when I say wrong lens for the wrong patient, we got to make sure what they're paying for. This we just did the clinical trials on. I'm very excited about it. I have not done it in anything but normal, virgin, I've never touched corneas because we can't in our trials. But the patients are extremely happy with the outcome of this small aperture lens. My friend, Dr. Bernard Dick, it goes through a larger incision. That's the only downside. The incision you got to make a little bit bigger. But Bernard Dick is using it in these post-RK patients, these messed up corneas, these patients with messed up irises, and they're doing extremely well. And this is kind of the Air Force target that you see comparing the IC8 on top with a diffractive multifocal and a trifocal. And if you defocus this lens like it shows about a minus 0.75, they see 20/20 at distance, 20/20 or better at near. They're happy patients. And will correct on its own up to about a diopter and a half of astigmatism. So it can rotate all around and it doesn't matter. And that's the important point, because we know that 10 degrees ends up about 2/3. We lose about a third of the effect, and 30 degrees we lose its all effect. I don't want to denigrate the light adjustable lens. My problem with the light adjustable lens, I love all involved. Steve Slade, rock star. Vance Thompson, rock star. Verdal, rock star. We got Eric Weinberg, head of the team. You know, a lot of people, but you have to enhance everybody with this lens, and it's expensive technology to have. But I love the concept. But what I know, we get good outcomes, but Warren Hill's getting pretty darn close to that if we'll just follow his guidelines. So if we can get in the 92 to 93% range, as opposed to this 75 to 80% range, plus or minus a half, I think we can do it. And I think we have the technology, and it's technology that's already in our offices. Now, I leave you with this last cool technology. This is in a rabbit, okay? They're taking standard hydrophobic acrylic lenses, and they're phase changing these with a femtosecond laser. They're altering the toricity of the lens, the asphericity of the lens, the spherical aberration. So let's say Miss Johnson had her cataract surgery, 10 years ago and's got an acrylic in. You're going to be able to come back and change that for her and get rid of her residual refractive error, whether that's farsighted, nearsighted, or astigmatism. I think you're also going to be able to take somebody who's got monofocal implants and say, okay, now I'm in a better position in life and I would like to read. Can you do that for me? And this is just showing that in this particular person, or this rabbit, they changed it 2 diopters. So we still have a bit of a hill to climb, but this is in Aspen. You can climb halfway up, or the tractors take you so far, and you get to climb all the way around to the top over there on the left. And boy, once you get over here and ski down, the skiing's so much better. So I tell you that we got to keep working at it. And again, I am so humbled that you guys have asked me to be here. I respect you guys so much. I was so impressed. You had like 12 to 14,000 people on that virtual conference that you all put together. I had literally 3 computers going at once so I could watch everything. It was phenomenal. So thank you all for being there, and I'm going to quit there and answer any questions.
Thank you so much, Dr. Karl. It was a very exhaustive and a very beautifully done presentation. You had really walked us through how to identify what to correct, what not to correct, and then how to correct, and then also to prevent those things from happening. So it was really a very good lecture, and thanks a lot for that. And then we have a lot of questions which have come up to us. So I again invite all our panelists also to answer the questions. So one of the questions is, you had shown that you are very fond of LRI, right, Dr. Karl? And what nomogram do you use in such LRI, means for LRIs?
So personally, I'm using the Woodcock nomogram for my laser astigmatic incisions. So it's Dr. Woodcock. He's out of North Carolina. That's readily available on internet. And then either Nickerman or Donenfeld. And I typically use the Donenfeld limbal relaxing incision.
LRS.
So I'm more of the Donenfeld limbal relaxing incision.
Okay.
Dr. Lionel, what do you use?
I don't use much, but as you said, I'll use DONS. Yeah.
Dr. Sujatha, madam,
I do these limb relaxing incisions mainly for my keratoplasty patients, not so much for cataract patients, and I also use the Donenfields.
Okay. So the next question is regarding the same LRI. How much astigmatism does this LRI correct? Dr. Karl?
Me personally, I don't like to treat more than a diopter. If it's more, I mean, you can. I just took care of a lady that had a wicked pterygium, 23 diopters. We just removed her pterygium, and she's now got a diopter left over. So she went from 23 diopters of corneal astigmatism to 1. So there's a lot of power in the cornea. But for me, at about 1 and above, if I have the opportunity to take the lens out, put in a stronger power intraocular toric lens, but I'll correct up to 2, 3, 4 diopters. But I'm like Dr. Lionel. At that point, I'm probably going to be using my laser as opposed to my incisions. But sure, you can treat easily up to 2 diopters.
What is
I agree with you, Carl. I also guess it should be a diopter or a diopter and a half, not more than that. And it's again making an incision on the cornea. So greater than a diopter, better not to only rely on LRIs. I agree with you.
What is your threshold for rival exchange if it's only a spherical correction? Dr. Karl, what is your...
So when do I start? I'm kind of like him. I'm more prone to do laser vision correction like you guys have mentioned on all these because it's so simple and quick for me. And if I take it out, what I do are the big refractive surprises. So every now and then I may have a penetrating keratoplasty, or I may have I had one guy that had 83 RK incisions. Don't ask me how that was humanly possible, but I counted them. They crossed incisions they had, and I said, look, let's try this first before we do anything. and we had a big refractive surprise. He came back as a +4. So I took that out and put a new lens in. But anything that comes out really hyperopic, +1 or more, I'm more prone to exchange the lens. Anything myopic, I'm more prone to do laser vision correction. I think it's easier to treat.
Do you have any conditions wherein you would avoid doing a LASIK, like laser correction?
Well, the biggest thing is the simple stuff we typically do with laser vision correction. Simply, you got to have a normal thickness, normal, pachymetry is important. I think in these patients, if we're doing a surface treatment, we've got a lot more room. If I'm worried that they've got bad blepharitis or bad meibomian gland disease, bad dry eye disease, maybe I'm more prone to do a lens exchange to try and not, make a LASIK flap and create more dry eye disease in terms of a person that maybe already has it. But I think for the most part, all these older patients do so well with PRK. My older patients have been through life. And I'm saying anybody 60 years older. And I'm not saying they're old. I'm just saying they've been through life. They've had babies. They've had car wrecks. They've broken arms. And when you do a simple PRK with ketorolac as pain management, and we use a dilute topical anesthetic, they see so quick now. These bandage contact lenses are like breathable. So I put them in a bandaged lens like a Air Optics or a B&L night and day, and they see 20/20, 20/40 the next day, and they're happy because they're probably seeing better than what the refractive error they had. And my laser vision correction, like I showed, that's why I showed the very first thing, has the opportunity to treat their topographic abnormalities or their wavefront abnormalities, and I can make them see 20/15 in a lot of instances by correcting those additional errors.
And if I can add, Preethi, to Carl's statement, specific to your question, I also had recently studied nearly, it's 264 cases, and in our population, given the South Indian population, dry eyes, nearly 60% had lesser ocular protection index, pre-operative. So that is a big concern, and many are diabetic with diabetic keratodystrophies and ocular surface changes. So that is the biggest, contraindication to laser vision correction post cataract surgery in our population. So that is something which we need to keep in mind.
And the other pearl along those lines are those hyperopic eyes, those really small eyes, 22 millimeters and less for sure. Those are the ones where effective lens position matters. So you're more likely not to take those lenses out and more likely to do some type of surface treatment, hyperopic or myopic, because you can take the lens out and where the new one lands can be a problem.
I have a comment. See, in our series, what we found was most of these patients requiring a correction where children who were operated at a very young age and they became slowly myopic. So these are the patients who've already had a lens inside, and some of their lenses have been, there's a pupillary capture, and going inside and meddling with those lenses was going to be a big issue. So these patients now in their maybe 18 and 20 years, they are the ideal candidates for a surface ablation. And this probably happened because of the wrong calculation and putting in a lens at a very young age. So this is the series that we see quite a lot in our hospital.
And at Pittsburgh and Kansas now, Dr. Dury's daughter, Erin, is now working with a lot of kids. Deep Waller is now working with a lot of kids. Marguerite did kids early on. So I think we're more comfortable if we have access to a laser suite. And kids are okay. I mean, we can do Versed and they'll lay still for 9 seconds or 5 seconds, usually, as long as you get mom in there or you play a game with them. So I operate on children under vocal local all the time. And you guys invented hypnosis. So, I mean, in terms of, some type of hypnosis with these kids works as well, too.
We call it vocal anesthesia.
Of course, absolutely. And women's voices are better than men, Dr. Lionel. I hate to throw you under the bus with me, but that soothing, calming voice of mom is always there.
The other point which I would like to add to what Dr. Lionel said was the incidence of MGD, that is meibomian gland dysfunction, is very high. I don't know whether the Agarwal group is also seeing that.
Yes.
I think every second patient has MGD, and so that is one thing we need to take care of before we take up any of these cataract surgery patients for surgery.
And in our
And we had
population,
a lot of success with the cheap technology. Sorry, Lionel, I'll forget. The low-level light therapy now, it's low cost per case, low entry. So we're using LLLT on the Chalasians, and I published that paper. So if you put STONECIPHER LLLT, it's in clinical ophthalmology and available, or STONECIPHER and IPL plus LLLT. Now, LLLT it doesn't have any problems with pigment. IPL does. So in darker pigmented individuals, we worry about IPL. I don't even use it. I use the LLLT along with expression, and I use a friend of mine, Juan Valle's spatula. I have no vested interest in that. And I think that we now, meibomian gland disease is sexy because we have ways to treat it. And I'm sorry, what were you going to say?
No, that's okay. I was just mentioning that, yes, I do agree with her because the reported incidence in India, especially with MGD, is it's very, very, if I'm not wrong, it is 15 to more than 50%.
Okay.
So that is to be taken care even before a cataract is planned for that particular patient. And Carl mentioned it very clearly. It is the main sources of failure. One is missed OST. Number two is missed ERM. So I really appreciate you because you brought both the points together. Yeah.
Yeah. And Dr. Sujatha, ma'am, you were mentioning that there is a lot of incidence of MGD. So when you find a patient having MGD, how long do you wait before you perform a cataract surgery, and what do you expect to be there when you plan?
So I definitely will not touch them unless I'm happy with their ocular surface. And my first suggestion would be to do a home remedy, because you don't want to jump in and give them some treatment which might put them off. So I would suggest warm compress and doxycycline and so on and so forth. And if they don't improve over a period of 1 month, then I would suggest an IPL. And in my hospital, we use quite a lot of IPL, and the results are fabulous. I'm really surprised because I was one person who didn't believe in the technology. I had it as a demo, and I'm seeing all the patients coming back for the second sitting because of the comfort that they felt after the first sitting. So that way, that is my second choice of doing an IPL. And once their ocular surface is improved and the meibomian glands are cleared, then that's a time I take them up for surgery, because these patients are the patients who are going to come back with constant irritation in their eyes. And after that, once you have done the surgery, it's going to be very difficult to do any of these treatments. So it's better to treat the ocular surface first, clear their MGD, and then take them up for cataract surgery.
Yes, because treating the ocular surface prior to surgery not alone helps in relieving symptoms, but also the accuracy of IOL power calculations. And also that post-surgically we are going to give several medications that may even harm the ocular surface. So we need to have a healthy surface. Yes, Carl.
And there's going to be a new drop. Tarsus Technology is going to present a new drop that will help us with Demodex and collarettes. And we looked at a study that looking at whoever's practice, it was between 50 and 60% of the patients have Demodex in their eyelashes in this refractive cataract population. Kids as well, MGD. So I think that Tarsus is going to be a nice step. Blefax or some type of rotary device which cleans the eyelashes, and blepharitis is inexpensive. And I teach the patient it's like getting your teeth clean. So I can't, even if I brush every day, I can't get all the plaque off. So I think that that's another option as well. That's inexpensive and doesn't cost a lot to the doctor.
That's so good. That's so good.
Yeah.
I have one more thing. What we do in a routine cataract workup, we do eye trace on all these patients. So when you do an eye trace, you know whether you have the aberrations arising from the cornea or from the internal optics. So when you have a patient who has a lot of abrasions on the cornea, putting a premium lens like a multifocal intraocular lens is definitely going to be a problem. So, and doing a topography and doing a night trace will definitely help us to choose the patients better than having a refractive surprise or a very unhappy patient post-operatively.
Yeah, and eye trace is very much like OBD3, so those are pretty exchangeable. So they're both awesome machines.
And,
I got both.
Yeah, Carl, if I just review through your presentation, you said your premium IOL enhancement rate is 1.6%, which appears it's a magic figure, really. So yes, so
but it takes a lot of work on the front side, and I'm just telling you, I'm constantly looking at my personalized lens constant. I'm collecting my own data. I don't have to have some glorious software. I just look at my own data on an Excel spreadsheet. I do use the other people, but I'm just saying you don't have to have that. It's not something that costs a lot of money. I do use internet-based refractive analysis. I think that's phenomenal software. I think that is about 700, 800 euros per year, but that looks at your refractive results. That looks at your cataract results. So if you're a resident and you're just starting out, that's a lot of money, I know, but it's a way to collect your data, get your own personalized lens constant. But if you can't afford something like internet-based refractive analysis, then I say go to Warren Hill's website. He has a ton of stuff for free.
That's good. And your enhancement rate with the laser refractive surgery is 0.29, right? 0.29%.
Yes,
And may I just ask you a question? How small the error you leave, you don't do any enhancement, and how great, how soon do you do an enhancement?
So I don't like to do an enhancement before 3 months. I'll do it sooner. If there's a guy named John Potter taught us, if you have a big refractive surprise, treat it early. Don't wait, because the patient is unhappy. So like I had a patient referred in to me that I did not do their surgery. They were minus 11 in this eye, minus 6 in this eye. The surgeon did it exactly opposite. They did the 5 and 11 eye. It was a minus 6 left over, and the other eye was hyperopic.
Yeah.
So they did a minus 11 in the 5 eye. And I said, lady, we got to fix this now, because they can't have time to think about it. Now, in the hyperopic eye, I had to do a lens surgery. In the myopic eye, I just did a little bit more LASIK. And I just saw her, she's about a year out now total, and she's completely thrilled and doesn't really even remember the trauma. Now, if I'd waited for 6 months and let her sit there and sulk over it, she would have been much unhappier of a patient.
Yes.
And really the most unhappy one was her husband, to feel like something had done wrong to his wife. So I think that the important timing is whenever the patient's unhappy. I'll even treat a 20 unhappy patient that's 20/20 in my lane if I have something to treat. You know what I'm saying? If they're plano and I've got an RMSH that's 0.45 or less, then I'm going to look at you and say, I can't do any better. Or if I'm worried about the thickness, I can't do any better. But I don't like to treat before 3 months is my preference.
Got it. So the cutoff, we should take it as 3 months from your...
Yes, because I think Guy Kazarian and I published series that showed at 3 months, that's pretty much what you're going to have at 3 years.
Yeah, even I do that. I'll wait for 3 months. Yes.
This is for the LASIK, right? Wait,
Yes.
3 months. Okay.
And regarding your toric, it is your success rate is 94%, right?
Yeah.
Yeah, against the reported average of 88.
Yeah, so my 94% is I use pre-operative, I'm calculating, using all the calculators online, whether that's an Alcon lens, a J&J lens, whatever. I'm doing all the calculations like Hill, I use Barrett, I use, what am I missing?
ASCRS.
Holiday, and I'm sorry?
ASCRS.
Yes, and then I use ASCRS, and then basically intraoperative, I'm using my aberrometry, usually dynamically. So I don't think the picture taking works as well as using it dynamically and watching the numbers as they go across the screen.
So you rely more on the real time
Yes.
aberrometry, right?
Yeah.
And you do you use manual marking system or?
I don't
Yeah.
really mark people anymore. I stopped marking. I'll mark them if I think I can't get aberrometry on them because they got a messed up cornea, messed up iris. But it's very rare. I'll probably mark maybe 5 or 10 people a year.
Okay. Got it.
And I use a robo marker when I do that.
Dr. Sujatha, madam, what is the marking you would do for a toric?
I use a Callisto. I use a Callisto on my Lumira, so I've also stopped marking after using the Callisto. It works very well.
Okay. So,
Now, how are we doing on time, Dr. Preethi? I don't want to keep everybody up past their bedtime. Are you doing okay? On time. Are we okay on time?
We have 10 more minutes for our discussion.
Okay, good,
All right.
good.
Good.
So that's why. And I would like to know, when do you rotate? Like Dr. Karl, when do you actually rotate a toric lens? What will be your cutoff limit?
Immediately. So if somebody comes in and they have a rotation, which I beat you over the head to be still, but my patients are very active. And I had one, this was probably about 6 months ago, that she decided to go run a 5K race. And she came back and her lens had moved. And I was like, it's your fault. I always make it their fault. It's your fault. You ran the race. I can't help it. Well, I didn't tell you could run any race. I said, for 2 weeks, I don't want you to do anything. I don't want you to walk. I don't want you to bungee jump. Well, I didn't bungee jump. Okay. I don't want you to parachute. Well, you didn't parachute. I got that. But I don't want you to do anything. And I think that's from David Chang's data. So I do it as soon as I notice it. The minute I notice it, I'm like, Dr. Sujatha, I want to get that rotated. I can do it late, but I want to get it rotated as fast as I can.
I do that a week later generally, and that is what is the regular teaching, a week or two later. But sometimes, like one of the cases which I also presented in EACRS, where I had a transposed axis during calculation. So all those things, we need to do it as early as possible.
What do you calculate and where do you calculate how you have to rotate? This is a very common question which comes up in a budding surgeon.
That paper, there is every single website how to calculate it. So in that picture, it's in the paper. We're going to make sure everybody gets a copy of that because it's in that paper. We went and found every website worldwide that you can go to calculate that with. So I would tell you, let's refer to that.
But I use Birdle Harton.
Yeah, it's good.
Yeah.
Dr. Sujatha, madam, your take on this? What would you use to calculate how much you should rotate?
I was using the eye trace for quite some time, but then I found that the calculation was wrong. And so what I do is I go back to my original calculation that we've already made, and I go back and do the same thing. So that is what, I have hardly done 3 in the last 1 year because of COVID and all that. And I think it worked out very well for me. One more question to Dr. Karl. I just want to know, what is a spherical correction that you would go in and exchange a lens for? Suppose a patient has -1. Would you still exchange the lens, or would you do a surface ablation?
I'll do surface ablation at -1. Really, in the hyperopic arena, so plus or -1, or more myopic, I lean towards laser vision correction. Once I get above +1, I start exchanging the lens for plus refractive error. And then if I do a lot of crazy stuff. And so like pellucids are a keratoconus where I can define an axis, got a big asymmetry. If I miss the mark on that and I put in a T8 and I got a T9 as an option, I'll go and exchange that T8 for a T9 immediately. So on those pellucids are those asymmetric bow ties, keratoconics, and they are some of the happiest patients. I used to do wedge resections and transplants and all those people. I had one guy that was left over -1, +3, and plus cylinder, what would be +2, -3, and minus cylinder. And I said, look, there's not really a whole lot we can do left. I could get you maybe a contact lens, reverse geometric, or maybe I could get you some glasses. And the guy looks at me and goes, Dr. Stoneciphер, I have never seen this good in my entire life. Don't touch me. I'm afraid you'll make me worse. So I think that we don't realize those multifocal corneas, if we can get them close, they can finish the rest, and then cross-linking will help us flatten them if they haven't been cross-linked. Those kind of things help too.
The other point is in patients with keratoconus, if they've been using contact lenses, they are very happy with their contact lens. They are much more happier than giving a correction in the lens. Even if they have cataract, the quality of vision that they get with a sterile lens or a mini sterile lens is much better. So I've had a couple of patients who have continued with their sterile lenses even after the cataract surgery.
Yeah, and I tell them that that's a myth, that they can't be, if I put an astigmatic toric lens in you, that's a total myth. You can still be fit with a contact lens. You find a good contact lens fitter, they can be fit all day long. But that myth is out there that people think, oh, if you put a toric lens in, you'll never be able to wear a contact lens again. That's totally false.
Yeah, what's your experience for using a multifocal in a patient who has undergone refractive surgery earlier? Like
in LASIK patients, that's probably today, out of every 10 patients I do, probably 7 or 8 of them are previous LASIK patients. And they love the PanOptics. I've had good success with it. I've had success with the Symphony, but they've been unhappy with the Near. So that's why I've shifted to the PanOptics. If they have a high abnormal quality, their RMSH is high, I'll use a Vivity and tell them they're going to lose Near. They won't get as much Near out of it. We don't have Eye-Enhance, and really that's it. The PanOptics is the only trifocal platform we have. So the other Synergy, other platforms, Zeiss Technologies, I don't have access to.
Do you use a plus 3.5 or a plus 4 in these patients?
In terms of, I don't do bifocal lenses anymore.
No.
So I never use a bifocal lens ever. I only use a
trifocal.
No, the PanOptics comes in two add powers, 3.5 and 4. So
for the PanOptics?
Yeah, PanOptics.
We don't get that. We're an island. Okay. You're a world. We're an island. We don't have that.
Okay. And what is the formula you prefer in post-LASIK cases, Carl?
So most LASIK cases, the Barrett has been the most accurate. I would tell you Barrett T no history has been pretty dog spot on for me. And then that I'm matching up with aberrometry. But we look at the ASCRS average. We look at the Hagus L. We look at the Barrett T no history. And then basically average those, see how they match up aberrometry-wise intraoperatively. And if they're a little disparate, like I had one that was 18 and intraoperative got 19, so I put an 18 and a half in.
Dr. Karl, the Barrett's calculator gives a calculation for -1. It aims for -1. It aims for myopia. Would you be
Which one does?
Barrett's.
You can always adjust that.
So I adjust that, ma'am. We can make it either slightly myopic or plano. We can make adjustment with the target values.
Yeah, and I mean, my RK patients, I may leave them a little myopic, but I found in the end with these newer lenses, plano, unless it's the small aperture, I'll adjust to about a -0.75, or unless I'm doing monovision.
Have you ever explanted or done a correction for glare and halos? Because you were saying that you do a lot of PanOptics in young male, right? So have you done any correction for the glare and halo? And how is the difference? Can we
or in other words, if I can reframe the question of Preethi, how is the patient satisfaction, especially for dim light and driving comfort?
I tell everybody they're going to have problems to begin with. So I say, everybody's going to get it. So everybody's going to have halos, glares, starbursts, show them pictures. I said, but whether you have that of a year, for me, it's 1 out of 1,250 that will have it, okay? But what is happening with these patients now is if I get somebody that's totally unhappy, what we miss the mark on is they usually have some residual corneal, not refractive error. It's astigmatism if it's left over usually. But if it's not spherical or astigmatic, if they've got a higher RSMH, and in many of those patients, I've come back and just treated their topography. So put in Plano and just treated their topography, which is usually about 6-7 microns. And I prefer to do that from a surface treatment, remove the epithelium and then laser. And these are some of the happiest patients I've ever seen. So topographic guided laser vision correction in those patients, I've made a big difference. And there's wide optical zones, so that makes a big difference too.
Okay. So despite you saying that you may have glare, how is the take for PanOptics? Like sometimes we find this, that when we say that you will have a distance, intermediate and near, but there could be little glare and halo, we ourselves find it little difficult to convince a young patient. So you have any specific method to convince yourself and the young patient?
Well, of course, we talk to them about pupil size, and we use bromidine, to make the pupil smaller and do different things. And I will try and give them as much time, but I never deny it's there. So for me, I'm saying, you're right, you got it. But I promise you, wait long enough, it's going to go away. And usually they get tired of it. Now, have I ever taken a lens out? Absolutely. But the one thing I'll never, ever do is deny it. I always go, yes, ma'am. Yes, sir. You're absolutely correct. That is it. I have one patient that I'm still working with, and I look at her and I say, she plays tennis. She's a really good tennis player, and she's young. And I said, you're 20/20 at distance. You're 20/20 at intermediate. You see better than 6/6 at near. I said, I can take that lens out, but I'm going to put in a monofocal lens and you're going to lose all that. And if you're willing to lose all that, I'm willing to take that lens out. And she hasn't done it yet. So I think there's some of those people that you just have to say, okay, this is what you've got. Can you live with it? This is the alternative. And you choose A or B, because I'm not going to choose it for you.
One more question. In case of, what do you think will be the best lens when you do an IOL exchange for negative dysphotopsia?
Yeah, for negative dysphotopsia, that's tough. Negative dysphotopsia, I've been doing a lot of iris capture. So Holiday talks, and he's got an article about, I laser away the anterior capsule first. So I laser away the anterior capsule with the YAG laser with a big dilated as pupil as I can. See if that helps with that negative dysphotopsia. If that does not cure it, then I'll do an optic capture initially because it's simple. But if I take it out, I'm usually using a Z9002 Technis.
Okay. Thank you so much, Dr. Karl, for the wonderful.
Can I just ask one question, Carl?
Yes, sure, Dr. Lyon.
Yes. You are talking on monovision. So monovision strategy, you said you will plan you will do the dominance testing, and you will try to make the distant dominant eye most often for the distance, right? The dominant eye for the distance. So that is 72%, if I'm not wrong. And which all cases do you prefer dominant eye to go for near?
It's most likely going to be an accountant or a seamstress. So the near dominant people are going to people that work at home, which you're seeing more and more people. They get out of bed, they make their coffee, and they go sit down at their desk now. And those are the people that their distance eye, which you would think would be their preferred, they'll want for near, their dominant eye for near. And it's near people that's all their whole world is. I have a guy right now who's a jeweler, and his dominant eye after cataract surgery, he made me make his dominant eye -4. Wow. And his non-dominant eye is Plano. I don't know how the guy walks around, but he does. Doesn't wear contact lens, anything.
Okay.
Yeah.
Preethi, just
thank you guys very much
thank you. Preethi, just before concluding, for the benefit of audience, so many good things that Carl has quoted today. One of which is a crucial, critical thing, which is pre-operative evaluation of the ocular surface. Please stain the ocular surface and see if there is any defect. Then look for the maculas. That is very much important. Ask for the history of smoking and, of course, the macular health. The topography that is very important also. You can do a dominance testing. You need to do when you especially plan for monovision strategy. Then develop your own A constant algorithm. There are several other things which can help you online, which is available, but try to develop your own. And finally, he talked on LRI calculators. He also gave an insight on light adjusting lenses and the future femto-assisted perfect lens. So I think all the audience would have got the information. So that finally, he also uses intraoperative aberrometry for the great success rate what he has, that is more than 94%. That's so good. Thank you, Carl.
Yeah.
And
Thank you guys again. And
Thank you
I'll
so
get all
much.
this information and you guys can figure out a way to email it to the participants.
Definitely. We do that, Dr. Karl. Thank you so much. Thank you so much, Dr. Sujatha, madam.
It was a wonderful experience. Really nice to interact with Dr. Karl, and it's a wonderful opportunity for me. Thanks a lot to all of you.
Thank you for being here.
Thank you so much, Dr. Lionel.
Thank you so much, Preethi. Thanks, Carl, and thanks everyone.
Right.
Thanks so much, Karl. And I
Thank you,
thank the
guys.
audience for their patient listening. I hope this talk will definitely help them grow. Thank you so much. Bye-bye.
Okay.
Have a nice day.
Bye.
Bye.